So welcome back, everybody. I hope you enjoyed lunch and catching up with people. Can everyone hear me now? Yes, brilliant. Right, our next speaker is Dr. Jonathan Segal, who is our pouch research fellow. So he's studying all things sort of medical related to pouches for his thesis, and he's been here for about 3 years now. And he's going to go through what work he's been doing over that period of time. And then Mr. Worley, who's our pouch surgical fellow, unfortunately wasn't able to come today. So he's passed on some of his slides. So Dr. Segal's just going to present some of his work as well. Over to you. Thank you.
Thank you, Lisa. First, it's a real pleasure to meet so many familiar faces and some new ones again. So thank you for having me to talk about this opportunity. So, as Lisa was saying, I've been here for 3 years, and I've fallen in love with the pouch. I think it's a strange thing to say, but it's been my thesis, and I've spent a lot of time researching it, and I just wanted to share some of these things with you today. So I thought we'd talk through some of the successes of what we've done with the pouch, and go through some of the things that we've managed to publish and get out in the public domain. So I know that we've been talking about complications of the pouch, but reassuringly, there are some things when pouches go wrong, there are things that we can do medically. So I'll tell you about some of the medical advancements we've done in pouchitis. Some of you may know that treating a complication called pouchitis involves antibiotics. But what happens when you're on long-term antibiotics? We'll talk about that. A condition called pre-pouchitis. Some of you may not be familiar about this, but I'll go on to talk about this. A service that we uniquely offer here, Biofeedback. I'll talk a bit about that. Things that are awaiting publications. And then I'll talk about some ongoing research, which hopefully some of you may be involved in or may want to get involved in the future. Before I go on to this, I really want to say thank you to everyone, not only here, but without any of this, without patients, without people like yourselves who give up their time and give us samples and allow us to use your data. Without you, we really can't do this. So thank you wholeheartedly from advancing the field and helping us with all this. So going on to talk about some of the management of pouchitis. So some of these are big words, and I'll try and break down them to you. So one of the things we looked at was we did a systematic review of everything that's been published on the treatment of chronic pouchitis. By doing this, we searched every single piece of literature that's ever been published on the management of chronic pouchitis. You may ask, well, why did we do this? Well, pouchitis itself happens in about 40% of patients who undergo a pouch for ulcerative colitis. It occurs about 40% at 1 year. Overall, for all of those patients that have a pouch, you can expect at about 10 years about 50% of patients to roughly get pouchitis. Reassuringly, though, most patients respond to a simple course of antibiotics, and that's the end of it. But there are this 10 to 15% of patients that grumble along with a condition called chronic pouchitis. And that can mean that patients have frequency, they have urge, they have pain, and it can be quite a nasty condition. And our knowledge on how to treat this before we really did this piece of work was quite limited. And so I thought this piece of work needed to be done. This is just what we did, and I don't want to go into it too much detail, but there's 2,954 articles we went through as a group. So quite a lot, but we managed to whittle it down to 22 seminal papers that focused on the treatment of chronic pouchitis that had been published. And when we looked at all the results together, so how do we best treat chronic pouchitis, it was shown that this little dot at the bottom shows that roughly about 60% of patients we can get back to health, or back to what we call back into remission. So not bad, but probably a bit of things that we can squeeze and get a bit of improve on. I put up antibiotics because a lot of you would have been familiar with antibiotics, and patients with chronic pouchitis are often maintained on long-term antibiotics, and this achieves them to get back into health in about 70% of cases. One of the real proud things I think we did with this piece of work is we constructed a treatment algorithm, and I don't expect you to read this, but this is out in the public domain. And I think when patients go back from St Mark's, we get them from all across the country, and they go back to their local hospital, and physicians are not used to pouches, essentially. So I think what this does is it gives, like when you go back to your district general hospital locally, this gives clinicians a real kind of idea of what to do, and you can get that. If any of you are interested in any of this research, I'm going to flash up the actual published work. Please take a picture on your phone or come to me at the end, and you can read these in more detail, but this is where it was. When I first started off, I encountered lots of patients with pouchitis who are on long-term antibiotics, and I'm sure It's been in the news a lot about superbugs and antibiotic resistance and all these things I'm sure you've all read. And this worried me as a physician. It was like, well, am I just giving my patients antibiotics? What's going to happen to them? Is there any complications? So I thought this piece of work needed to be done. And as I've already mentioned, you usually give long-term antibiotics for that chronic group of pouchitis patients. And this, again, happens about 10 to 15% of all patients with pouchitis. And as I was saying, we don't really know the safety and long-term effectiveness of giving patients antibiotics. We tend to just give them and hope at the time that these are making them better, but we really didn't know. So we wanted to assess the long-term outcomes of what happens to these patients. So what we did is all patients who have been on antibiotics for their chronic pouchitis for greater than a year, we followed up. We looked at their notes retrospectively and followed them up for as long as we could. This often was looking at their last clinical appointment. And what we found was that in our cohort, once giving long-term antibiotics, sadly only 20% managed to get off them. So 80% who were put on them long-term stayed on them. Now I want to talk about pouch failure. And it's a word I don't really like using, actually, because I don't think pouch failure is fair. And what I mean by pouch failure is when you need surgical intervention to make it better. Now, in my eyes, I don't think it's necessarily a failure as such. It's just an alternative. And for some patients, having a shot at having a pouch, some patients get away with it and are absolutely fine and are great with a pouch and have a life. We've got patients 30, 40 years with a pouch and have never had any problems. Some do, but I think it's worth having that shot. So I don't like the word pouch failure. But in this case, it will mean those who needed surgical intervention to fix their pouch problems. One of the things we were really worried about was side effects of the antibiotics, and we all know that there's side effects that come with antibiotics, such as the two common that we use are ciprofloxacin and metronidazole. Ciprofloxacin has been associated with Achilles problems and metronidazole with nerve problems, so we were really specifically worried about this. Fortunately, minor side effects only occurred in our cohort, but the worrying thing was there is a lot of resistance that built up to antibiotics. Nearly 80% of patients built up antibiotics resistance, which did worry me. So the conclusion of this was, although antibiotics for chronic pouchitis may be needed, we have to carefully think about the complications, the side effects, and only really use them when need be. And I also think it means that we need to constantly search for new therapies for patients with chronic pouchitis. And this will lead me to some of the work I'm doing later on in my talk. And again, for those of you who are interested, you wanted to read this, it's out in the public domain, and you can read it here. Another thing that we were interested was some of you may have heard of this complication called pre-pouch-ileitis. It's fairly rare, but because we have such a high volume of pouch patients here, we see it more and more common. Just to explain what pre-pouch-ileitis is a quick schematic of the pouch. So you've got the pouch main body, and just above this is essentially a small bowel. And in some cases, that small bowel gets inflamed. And we really don't know what it meant. Does this mean it's pouchitis? Does this mean it's Crohn's disease? People were really confused. One of the things the Americans do is they used to label this Crohn's disease, and probably inappropriately, because what we found here is this doesn't reflect Crohn's disease. But I go on to talk about this in a bit more detail. And the reason why we thought we should look at this is because back in, I think it's 2009, we looked at short-term outcomes of patients with pre-pouch-ileitis, but again, we don't really know what happens to these patients in the long term. And I think we really owe it to our patients to be able to tell them, if you have pre-pouch-ileitis, in 5-10 years' time, this is what you can expect. Just to go on a bit about what pre-pouch-ileitis is, please stop me if anything you don't understand. But pre-pouch-ileitis doesn't have a standard definition, so it hasn't been formally defined. But it is any inflammation that is just upstream of the pouch body itself, and hopefully that diagram showed that. As I said, it's quite a rare phenomenon. Only 6% of patients with a pouch can expect to have this, but we really don't know what it meant. So again, we followed up all patients who had been diagnosed by a camera test or endoscopy that had pre-pouch-ileitis, and we followed these patients up for as long as we could, as long as we had data from them. Because it's a fairly rare disease, we only managed to follow up 31 patients in total, but we followed some patients up until 98 months, so we had some good long-term follow-up on these patients. And again, I wanted to say this pouch failure just means that they've undergone a surgical procedure, but about 25% with pre-pouch ileitis underwent a surgical procedure to fix this problem. As I was saying earlier, it's not a strong predictor of Crohn's disease. So if you've got pre-pouch ileitis, some physicians out there will say you've got Crohn's disease. Our data suggests that is not true. And one of the things that we also found that pre-pouch ileitis seems to be persistent and associated with pouchitis as well. So if you've got it, it tends to mean that probably it's a poor prognostic sign, which means you're likely to do a bit worse on antibiotics and treatment. Please.
Can I just ask what the key symptoms are?
So very similar to pouchitis often, and it's often when you go to endoscopy that the small bowel itself you'll see is inflamed. So that's how you really diagnose it. But we found that this is probably a poor prognostic sign. It's associated with a high incidence of the need of surgery. It seems to be a more treatment resistive than pouchitis in itself. But again, I think we need to do more research into finding out how to best treat this and treat it better. And again, if anyone's interested, this is out in the public domain as well. And I want to talk about things that I think are really exciting and biofeedback in patients with a pouch. So I don't know how many of you know what biofeedback is, but I think it's a wonderful resource we've got here. So I'm sure you're aware sometimes conventional medical therapies just don't give you the outcomes that you want. We can throw as many treatments at you, but sometimes it just doesn't do what patients need. I think sometimes what patients need actually is to be listened to and to have opportunity to speak and explore their symptoms. And I think sometimes that can make patients feel a whole lot better just by able to do that. And this is essentially what biofeedback is. So biofeedback is like a behavioural therapy, and we've got some specialist nurses here who deal with all things that essentially conventional medical therapies don't treat that well. And we've used it in patients with problems with a pouch, and in particular, those who have defecatory problems, so struggle to evacuate, and those who have incontinence problems as well. But it's really never been assessed, is this actually effective for patients with a pouch? And so we wanted to really look at what our data shows. Is it shows that it's being effective? Are patients benefiting from this therapy or not? So again, we recruited all patients who had undergone biofeedback therapy here at St Mark's for pouch-related problems. And in particular, we focused on those who had incontinence and those who had evacuatory problems as well. And we recorded all patients' subjective improvements. So how did they feel that the biofeedback sessions treated them? We also used 2 validated questionnaires to explore their symptoms, both prior to the biofeedback sessions and after the biofeedback sessions. And we managed to recruit 26 patients for this. 11 reported some improvement, 9 reported much improvement, and only 6 patients didn't improve at all. But I think it shows that in some patients, it does offer something. And one of the other things that I thought biofeedback was really good for, when we used the validated questionnaires, we found that it significantly improved patients' quality of life. I think this maybe reflects the fact that we're giving patients the opportunity to talk to us, to explore their symptoms. The sessions are an hour-long session, so it's not a 10-minute appointment you get. And I think it also allows patients to feel listened to. I think it's a really valuable thing that I think really does improve quality of life. What biofeedback also does was, in our cohort, is it reduced patients' pain, it reduced bloating symptoms and feelings of straining, and it also reduced patients' need for laxative abuse. So I do think it has a role in patients who have problems with the pouch. So just to take home message for this, I think biofeedback is valuable, it improves quality of life, and also improves other problems that can be related to the pouch, and should be something that may be considered when conventional therapies don't work. And again, if anyone's interested, this is the publication here. So before I said that there's need for new therapies, I mentioned that pre-pouch ileitis is associated with a high incidence of pouch failure. I've told you about the problems with antibiotics and side effects. And some of the new medications that we've been trialling here, some of you may have used them, are some of the biologic drugs. So drugs like infliximab, vedolizumab, adalimumab. Then these may be drugs that you may have had for those with ulcerative colitis, you may have had it, but we're starting to use it in patients with a pouch as well. But there are problems understanding the real effects of these treatments on patients with a pouch. And this table here is just to show you the published literature on patients with a pouch who have had a biologic. And all I want you to appreciate here is all these publications have very small numbers of patients in them. So 7, 4. So to really gather a really understanding of what's going on, we're using small amount of numbers to understand, to use our knowledge. And I think we need to do a bit better than that. We need to try and pull larger numbers together to really understand it. But in doing this, it is difficult. So pouch surgery is relatively rare. It only happens really in a few centres. Pouchitis, as I've already said, is relatively rare, and chronic pouchitis even more rare. So as you start getting down to these numbers and patients requiring biological therapies, we're really dealing with a small number of patients. So I thought we need to try and improve this. How can we get more numbers? How can we really understand better? And my objectives of this study was to really assess the effectiveness of a common biologic, which was called infliximab. Hopefully some of you may be familiar with it. And by doing this, what I did is we used a multi-centre approach. So I approached many centres around the UK, some in New Zealand and some in Australia. And I invited them to give us their data on all patients that had a pouch or had biologics. And by doing this, we recruited 34 patients, which I think is still better than the 4, 5s and 6s that we had. So still not massive numbers, but we're starting to get a better idea. We followed patients up for almost a year, and in some cases up to 4 years. And what I was really impressed by was in patients who start on these biological therapies for their pouchitis symptoms, we can avoid a stoma at 1, 2 and 4 years in 82% of patients, 76 and 70% of patients. So we're starting to show that some of these drugs may start being effective, and we can start avoiding ileostomies as we start getting better with some of these treatments. One of the other interesting findings was, I think that if you're going to start infliximab and you are going to struggle with it, we tend to know quite early on, within the first year, that you're going to struggle with it. So those who manage beyond a year, we found that they tend to do quite well. So again, I think these are advances we're making in understanding medical therapies. And overall in our cohort, nearly 3/4 of patients did avoid a stoma, which I think is a good outcome actually. I think that's pretty good. I think one thing this study didn't do though was ask about quality of life in these patients. I do think it's one thing asking patients to grumble along with symptoms and keep throwing medications at you, or go for the alternative, which may be a stoma, but may improve their quality of life. I think that's the key thing we always need to focus on when we're considering giving medications, is what best is going to give my patient the best quality of life. And these need honest and open discussions, I think. So in conclusion to this, I think infliximab is an option for patients with a pouch, and a stoma can be avoided even in those patients who escalate onto this treatment. But I do think we need to be carefully counselling patients about all the alternatives considering this. And then I want to talk about my last real study, and I think this has been one of my real, I think, successes actually in a study. So this is looking at the effectiveness and how acceptable this new anal device is for patients with incontinence following pouch surgery. So it's kind of quite common actually that incontinence happens after a pouch, and there's a variety of reasons for that. But some patients, up to 25% in the literature, have been reported to have incontinence at night, and we're talking about fecal incontinence here. And incontinence is difficult to treat, and I think it's also underreported. Patients often embarrassed to tell the physician they have it. Patients often hide it. So I think it's even more common, and it's something that I think we need to do better at treatment. So one of the things that came to market is this device called a Renew anal insert, and I'll show you. I've actually got one. If you bear with me, I'll probably get one out of my bag. Oh, you've got one there. Fantastic. Has anyone not seen these? I wonder if we can pass a few around. Is that possible? Please pass around. So I'll let you have a look at these. This is what we've been using. So we've been using this device called the Renew anal inserts for patients with incontinence. But we didn't know if it's safe, and we didn't know if it works in patients with a pouch. It's been used in other forms of incontinence. The device is being passed around now, but it's really simple. It's an inert silicone plug, essentially, and it's very easy to use. You get an applicator. It's a one-use, so you essentially use it once, you go to the toilet, and it empties out. I really want to know, does this work for patients with incontinence with a pouch? Is it effective? Does it work? And so we did a prospective trial with this. So I was finding in clinics, I was getting a lot of patients with pouch problems that are having incontinence, and I really wanted to help them. So we designed this study where we offered patients for 14 days this plug. What we wanted them to do was to fill out a questionnaire before they used the plug and after they used the plug, and also tell us, whilst using this plug, how many times they ended up leaking. And did they find the device worked, and did they find it effective? So what was interesting was quite a lot, up to 50% of patients found that the plug was useful, and about the same amount found it acceptable as well, meaning they found it comfortable. When we looked at the validated questionnaire, we found that it significantly reduced patients' incontinence at night, which I think is really important for a patient. You can say to a patient you're going to be able to sleep during the night, and often patients are reporting this. They're now being able to sleep. They're now having more energy. And I think it's a really good study, and something that I'm quite proud of, and something that patients after the trial are still asking me to continue prescribing. So I think we'll see this staying, and I think it's really a new thing for incontinence and something that will be successful. I just wanted to touch on some of the ongoing research that's going on. There is plenty in the pouch world and still plenty more that needs to be done. One of the things I think I've touched on throughout my things is quality of life in patients with a pouch. And I think everything comes down to quality of life. Whatever we do, whenever decision we make about whether to have a pouch, whether to have a stoma, comes down to quality of life. And I think one of my bosses says very well what a pouch is. A pouch is potentially a quality of life operation. It's an aim to improve patients' quality of life, because there is an established alternative such as a stoma. So what I wanted to do was to assess, once patients first have a pouch, what happens to their quality of life over the next 3 to 10 years. So we can really say to a patient, at 3 years this is what you're going to expect. At 10 years this is what you can expect. So, as I've said, its aim is to do a pouch surgery is to improve quality of life, but this has never actually been examined with what the World Health Organization quotes as quality of life. There has been some studies that have looked at this, but what these studies do is they use a snapshot in time. So they will take you at 6 months and say, what's your quality of life there? But I'm sure you're aware quality of life changes throughout your life. Different things happen. Your pouch change, your bowel habits change. And so I really think it's really important to do longitudinally. So this study will be the first ever longitudinal questionnaire where patients first get a pouch, and we'll be asking you to fill out a series of questionnaires. And you can see here there's a list of questionnaires, and I really think this is important because quality of life means different things for different people. For some it's being able to go to work, for some it's being able to play with their kids, for some it's going for a run or a bike ride or whatever that may be. So all these questionnaires try to encompass everything about what patients can consider is important to quality of life, so you can really get an important snapshot. These include body images, our ability to go to work, and loads of other things like that. A company have built our website, which are called Lightmaker, and the reason why we used them is because we needed the data to be secure. Patients are going to be giving their online, they're going to be posting their information online, so we need to make sure this information is safe. This company have built the Royal Bank of Scotland website, so you can imagine these need to be encrypted and safe, so we trusted them with that. If it's good enough for Roger Federer, it's good enough for me. And they're also quite familiar with drugs as well, if anyone gets that during. Anyways, so this is the online platform that we've used, and essentially what happens is patients come to us, we recruit them for the study, they get a unique login to this website, and every 6 months you'll be emailed to your personal address these questionnaires. And you can see it's quite easy, hopefully. They're drop-down boxes. I think it's quite user-friendly. You tick on the boxes, things about your past medical history, sliding scales about quality of life, rating 1 to 10, yes and no boxes. And I think it's a really nice format, which I think we're quite proud of. And in doing this, we hope to really capture patients' quality of life. And if any of you are particularly interested in helping with this, I'd really appreciate if you can get in touch and we can help with this. But I still think there's a lot more to go, a lot further to go. And as I tried to show you, the treatments aren't perfect, and I think we can still get better. And this is where some of the science comes into my PhD and my thesis. And I'm grateful for many of you in the audience who I know have donated samples to me, urine, stool, blood samples, to help me really work out what's going on with pouchitis. I don't want to get too scientific, but one of the things we think drive the cause of pouchitis or inflammation is the bacteria in our guts. And we've known or been shown that an imbalance in our bacteria in our guts, which we call this flash term called dysbiosis, which means imbalance, has been associated with inflammation. But as yet, we've not been able to isolate a specific bacteria that causes pouchitis. One of the reasons suggested for that is it's not actually the bacteria themselves that cause this inflammation, but what the bacteria are doing as a collection, so the breakdown products of the bacteria that might be causing this inflammation. So this has led me to think, well, can we actually analyse these breakdown products? Are we looking in the wrong thing when we're just looking at bacteria? And can we analyse the breakdown products that the bacteria produce? And we call this metabonomics, or the breakdown products. So hopefully this isn't getting too scientific. But what metabonomics is a study of the unique chemical signatures or fingerprints that each cell in our body leaves behind. And by studying these things, we may be able to find out it's that chemical that actually causes inflammation, and therefore look back at where that chemical is produced and find new targets and potentially predictors of patients who may do well and may do badly. This is just a schematic to essentially show you what we're looking at with metabonomics. Essentially, we're looking at the breakdown sugars here, nucleotides, which are a bit like DNA, amino acids, which are a bit like proteins, and lipids, which in other words are fats. And these are the things we're looking at about the breakdown products to really get to understand what's going on. So with your help, I've managed to recruit 20 patients. We've used a control arm with those who have a pouch for familial adenomatous polyposis, because they tend to not get this pouchitis. We've taken cohorts both on and off antibiotics to see if that makes a difference to patients' metabolites. And we've taken a whole load of samples, so stool samples, urine samples, blood samples, biopsies, to really understand this. And we hope to correlate all the findings with those who have responded to treatment, those who haven't responded to treatment, and to try and come up with new novel techniques and targets. And what we found so far is that patients with healthy pouches and those who haven't got healthy pouches have difference in their metabolites. We're needing to analyse this much more further. We're in the process of doing that now, but I think there's some interesting signs and potentially things that are coming out of it. So I've gone over that already, and the reason why we're doing this is because it's yet to be extensively done in patients with pouches. It's starting to be done in ulcerative colitis, in Crohn's disease, for this. So the conclusions to my research is I think we've identified treatment algorithms to help clinicians out in the general public. I think it also helps patients. I think we're starting to understand what pre-pouch ileitis means. So if you've got it, I think we can offer patients things. I think there's new devices and new treatment options on the horizon for patients with complications. And we're starting to appreciate some new mechanisms of how pouchitis works. And importantly, we're doing work to assess quality of life in patients with a pouch. I know I've only got a few